Good evening, doctors. Welcome back once again to the free webinar conducted by Online Dentistry. Thank you for joining us early. Please make yourself comfortable while we continue to admit the candidates into the webinar. All candidates who require a certificate of participation for the program, please ensure that you have registered a free account on our website and have enrolled for this program. Good evening, doctors. Thank you once again for joining us early. Please wait a couple of minutes as we're admitting all the candidates on Zoom and as we're stabilizing YouTube. Kindly bear with us. All candidates who require a certificate of participation for the program, please ensure that you have registered a free account on our website and have enrolled for this program. Dear doctors, you can sit back, relax, grab a pen and paper as it's going to be a knowledge pack session. Here is our timeline from 2008 till present in a minute. Good evening, doctors. Welcome back once again to the free webinar conducted by Online Dentistry. Thank you for joining in early. Online Dentistry is a firm dedicated to imparting quality knowledge to dentists globally. Our motto is to redefine the dental education system that is available to dentists, and we have been striving towards the same the past 13 years. Here is our 12-year history in numbers. As you can see, we were established in 2008. Until present, we have conducted 122 offline courses, 400 plus online courses, and we have a total number of followers of 15,500 plus on all our platforms combined. This organization was founded and is led by none other than Dr. Binu T. Abraham. Sir is a dentist by profession, but a teacher by passion. Sir is a world-renowned speaker and has been the keynote speaker for ISPPD for the past 6 years. He's a teacher who simplifies the clinical concepts in dentistry so that practitioners can implement them the very next day. Introducing the head of academics, Professor Dr. Joby Peter. Sir is the former professor and head in the Department of Periodontics and Pediatric Preventive Dentistry. Malabar Dental College and Research Center, Edapal. Sir is a passionate teacher and a veteran pediatric dentist. Sir, throughout his career, practiced and preached the philosophy catch them early and watch them grow. Over the past 6 years, online dentistry has grown to 10 centers across India, truly redefining the concept of continuing dental education. We thank our coordinators at each center who have supported us throughout the years. All offline courses are at present suspended due to the restrictions of the pandemic. We have been receiving several requests all along this year regarding the offline courses. And if the situation of the pandemic resolves quickly, and we are hoping it does, we will be coming out with an offline course soon this year. Regarding the types of webinars we conduct, we have both free webinars and paid webinars. Here is the list of free webinars that are coming up on our platforms. As you can see, we are bringing out topics that are least explored by dental surgeons, but play a pivotal role in clinical practice. We are trying to put together the best teachers in each field so as to help the entire dental fraternity to advance into the next generation of clinical practice. This month is indeed a knowledge pack bonanza for all the candidates. So make sure you enroll for the programs by visiting our website www.onlinedentistry.in. Two of the must-mention programs in the coming up month is the session about CBCT, which can definitely redefine the way clinicians practice and preach through CBCT. Next up is the temporomandibular disorders coming up on our platform by none other than Professor Dr. Deepak Deryani, sir. Sir has previously done the same session on our platform and much appreciated it was. Online dentistry is coming out with another free international symposium on the topic mouth breathing, which covers two key concepts. One, the 7 clinical indicators of sleep disordered kids, and mouth breathing in proper and its holistic management. Do not miss this free opportunity to learn from the masters this Sunday, 23rd May 2021 at 8 p.m. IST. We also have a great news for the final year students who are watching this program. Here are the next 2 free sessions of Exam Alert initiative by Online Dentistry. On 20th May, we have the 10 short notes rapid review by none other than Professor Dr. Priya R. Nam is a professor in the Department of Conservative Dentistry and Endodontics at Malabar Dental College and Research Center, Kerala. And we have on 21st May, 10 difficult concepts made easy in oral medicine and radiology by none other than Professor Dr. Utkal MP. Sir is also a professor in the Department of Oral Medicine and Radiology, Malabar Dental College and Research Center, Kerala. Another proud announcement on online dentistry going international. Dear doctors, online dentistry is officially associated with the Faculty of Dentistry, Lincoln University, Malaysia. It is indeed a milestone achievement for the team. We thank all our dedicated candidates who have attended our programs and helped take online dentistry to the next level in dental education. We also have upcoming programs in the subjects oral pathology and oral and maxillofacial surgery coming up in the next weeks. So students who are watching this session, make sure you are following us on one of our WhatsApp groups or through our website where we publish all details of the upcoming sessions. For more details about us and about our programs, you can visit www.onlinedentistry.in. If you are not yet a member of our WhatsApp groups, please send us a message on 919847032032 or 94463 Thank you for your patient listening. Now over to the speaker of the day, Professor Dr. Joby Peterson.
Thank you. Thank you, Dr. Joe. Am I audible?
Yes, sir. You're loud and clear, sir.
Okay, fine. I'm just sharing the slides. Is my slide visible, Dr. Joe?
Yes, it is, sir.
Okay, fine. Thank you so much. I can see the same for the past couple of weeks. I can see Akash, Dr. Nasir, Arya, please on the videos. This session, this session, I can really help you if you on the videos, and if you are at a proper attire, and if you can on the video, I can really help you. This is not gonna be a conventional webinar where you lie on your couch or sit in your cupboard or walk and learn. It's not that way. This is going to be a very clinical application of muscles of mastication which we have missed there. So thanks a lot for coming in large numbers again, and especially more practitioners. When I see, I'm so happy. But this is even applicable to all the dentists at one point of time. When you listen to me today, one point of time, when a question or when somebody says about something, you will be clearly able to explain the concept. See, if you know the basics very thorough, in your clinical practice you will be the master. That's a very important thing that you should understand. So at some point of time, whichever year you are, whichever a number of years of practice into you are, you will be getting a lot of tips today with this session there. So the clinical application of muscles of mastication, I have, you can search net, you can search Google, know where you can find out a condensed format where says that muscles of mastication has got a clinical relevance, and this is also a part of a practicing dentist. It is not there. If you search YouTube, they say if you search clinical application muscles of mastication, you say okay, points by points by somewhere it will come. But how we can relate the muscles of mastication into our clinical practice, this is something that you have to be with me till the end of my presentation. Each slide is very important there. In 1994, on an August Monday 7th morning, I walked into this institution as a child, you can say that. And my first class is anatomy, because I have the list. So I have to go into anatomy classroom. I started climbing the steps of that 7-story building, which you can see there where anatomy class is there. But you can't use the lift because your seniors are there. The seniors will give you that look if a first year guy is standing and using that lift. With that look itself, you should understand that I should not stand nearby, I should run. So you have to start climbing. Those days it was very strict. So as a young person pursuing it, new into the professional field of medicine or dentistry, I started climbing the floors by manually, and I reached the department which I was destined to reach, the anatomy dissection hall. How many of you remember that anatomy dissection hall when you entered first, when you opened the door, the smell of that formalin? Can you forget that in your life? You can't. Even I experienced, still I have that pungent smell that brushed my face when I entered there. I was hesitant to enter, but you have to go there. You have to be there. I walked towards my table. Each person has allotted a table, like everything is written there. So my table was there. So I was walked towards the table, somehow adjusted with that pungent smell. And after a while, I just collapsed. I could not stand. I was feeling giddy. I was feeling suffocated. I was feeling uneasy. Finally, I just collapsed. Luckily, somebody caught me. I did not hit the floor. This has happened to me. How many of you have experienced this in your first anatomy class when you entered? You feel like puking. You felt like so much discomfort, disoriented. And how many of you fell out? I did that. I'm openly telling you, I did that. So once I got it back, I thought this is not my piece of cake. This is not my piece of cake. This is not where I'm supposed to be. or should be. But let me tell you, amazing teachers we had, and I don't know how many of you know Dr. Arunachalam Kumar was an amazing personality, and Dr. Sridevi, who was our in charge. So many amazing teachers really mold. And my presentation is today. Both of them, Dr. Sridevi and Dr. Arunachalam, are not in this world now. So my presentation is actually, I'm just dedicating to those teachers who made anatomy so thorough, and how to approach is what I'm going to present you. This is what I've learned from them and I'm presenting it to you. I hope this will be useful. But I'm going to tell a story at the end of my presentation. If you have strength enough to be there at the last slide of it, I'm going to tell you a story which can motivate you a lot. So be there till the last slide, which I'm going to tell that some discoveries we have done in anatomy. Let's see that. So the aim of my presentation is very simple: clinical application of muscles of mastication, palpation of muscles of mastication, finding out some trigger points. What are the trigger points we are going to deal with in detail? Refer pain. So even if you are, any year you are, or even if you are a practicing dentist also, you will get some highlighted points like referred pain, what it is, how it is happening, what is the basic pathology of that, how to palpate muscles of mastications there, and something that is coming in dentistry which we should be prepared. I'm telling you, it's already started long back, is myofacial pain dysfunction syndrome. Believe me, that's the separate branch is going to come, like implant is come, separate branch is going to come. It's already there, called myofacial pain dysfunction syndrome, a separate branch you can anticipate. If you want to learn more about it, these sessions are very very important about it. And as I told you, if you are listening to me, please, because we have some case discussions, we have some video demonstration. I will be showing you some video demonstration, how to do that. So I think Dr. Joe, you can spotlight me from now onwards, so that you can see my videos there. Very important, very very important. I'll be showing live video demonstration there. And if you have a pen and paper, please note it down. Please don't come and ask in the WhatsApp group, can you repeat it again, can I get a recording of this session? There are some reasons why we are not doing it. We love to be with together. I can see so many faces listening with pen written. They are eagerly waiting for that. That's the way we should learn. We should be a little serious about when we want to learn. So this session is going to be in that way. So try to be prepared yourself there. A 32-year-old female patient walking into a dental clinic with severe pain. Her mother is telling, my daughter is having a couple of days severe pain. She's night she's getting up, daytime she's having pain. The off and on she's getting severe pain there. She can't brush it, she can bite it, she's for the past 1 week she's having semi-solid food, not even hard things she can bite. That's a condition there. So we did an oral examination. When the oral examination is very perfect, only she had one filling in a molar. A molar has got a distal side of the molar has got a small amalgam filling. That's all, nothing else. No other history that you can elicit there. IOPA, you can take it, you can't find anything relevant there. OPG you can say, but nothing relevant in the OPG also. So sometimes we say that amalgam filling can have a pulpal involvement, and its metal filling you can change into a ceramic filling like composite or a GIC. Still the patient comes back and says the pain, then say let's do root canal for that. You do root canal, you do cap for that, but still patient says that that pain still lingers on. Now what to do? No idea about what is happening there. What have you missed there? So that tooth is not pulpily involved. We can find there is sufficient dentin there. No perio problem, food impaction. Sometimes we say it's a food impaction, food is getting impacted, bone loss is there. You do perio surgery, you do flap, open up the flap. You do so many things you do there, but still patient is, still the pain is lingering. It's still there. It's no reduction. When you give some medications, no analgesics you give, no, you don't know, but you give analgesics. Initial 1 week it was good, but again it started because you did a perioflab. So you have to give an analgesics. So that 1 week you have analgesics, fine, patient is fine. After that again it started recurring. Same thing for root canal also. After 1 or 2 months, patient will be happy. After again start occurring there because you give an analgesics there. So history is important. History is very, very important. Here, the patient says, this tooth is big. This tooth is paining. I have pain in this tooth when I bite, sometimes without anything. I can't have hard food there. Pain is there. So it is a pain history. Whenever we have pain history, we dentists automatically assume pain is due to pulp. Only pain that you can have is pulp. Pulp is involved, closer to the pulp. Something related to pulp is all our idea or thinking goes. So definitely that is why we take an OPG, we take an IOPA, occlusal view, everything we'll take to rule out the pulpal reason. What else can have? What else would be the reason for this? We are not aware about it because we always pain means pulpal pain, odontology or pulpal pain. That's it. So that pain could be due to pulp or associated things. Did we miss a hidden problem here? Now coming to the problem of, have we missed something? Is pain, the moment we hear pain by a patient, especially a dentist, is it only related to pulp or can it be something beyond that? That's a, did we miss a hidden problem here or not? Now, let's keep that aside. Let's see what Dr. Binu said yesterday. He told about skeletal muscle. He never talked about pain and pulpal pain. He just talked about basic anatomy of muscles of mastication. So beautifully explained. Now, let's see, can we correlate both? Is there is some logic in correlating both together and we can have a better or a third eye view? Okay, this can be also due to this guy. So let's see skeletal muscles. The skeletal muscles are the muscles of mastication are a skeletal muscle because they are attached to skeletal. You know, skeletal muscles, and skeletal muscles are all striated muscles, like a striation strips are there. Somebody has drawn some lines. Strips are there, light and dark strip. That's why it's called striated muscles, and they are voluntary muscles. One more thing, voluntary muscle is very important because many of the dentists prescribe some drugs which are exclusively for smooth muscles and they prescribe for muscles of mastication pain. Yes, for example, Meftal MR. Meftal MR is a muscle, is a drug which many of the dentists prescribe. Let me tell you, you go and search this R for smooth muscle like intestinal cramp, menstrual spasm. This is good. These muscles, these drugs are good, but for not for striated muscles. Another important point. I hope you got one point today, that while prescribing for muscles, make sure the drug act onto the skeletal muscles, not onto the smooth muscles. So do not prescribe right royally this for all those things there. I'll come to that towards the end of my presentation, NSADS, which one you should prescribe there. So that is why I put this slide, that skeletal muscles are striated muscles and they are voluntary muscles, not smooth muscle or involuntary muscles there. So there are certain drugs to be prescribed only for these muscles there. Otherwise it is waste. Now, because they are fast twitch muscle, not slow, like an intestinal muscle, they are slow. Peristalsis, they are slow movement. It's not fast. You have to act fast type of activity. That's called type 1 muscles, quick and powerful movement. Their contraction or action is like a bang. That kind of faster it is, more powerful force is generated by these muscles there. So let's see, when you are writing or when I'm talking or when I'm swallowing or clenching, what happens to the muscles of mastication? All striated muscles are same. And let's see how this what happens inside when we do an action with a striated muscle. You are doing an action. It can be phonation, it can be swallowing, it can be clunging, it can be biting, or it can be like forward and anything. All the striated muscles, when you subject to an action, what happens there?
Skeletal muscles are composed of bundles of muscle fibers. Muscle fibers are long cylindrical cells containing several nuclei.
So this is the basic component of a skeletal muscle. The bundles of fibers are tied together. So basics, just like straws, a pack of straw you take and hold it together. That is a skeletal muscle. You can imagine like that. It's packed together, and one of the straw, if you take outside, so many straws are there which are packed together, and one of the straws you take together, that's called muscle fiber, and inside that there are multiple other straws kept inside called muscle cell. Each one you call it as a muscle cell, and inside that muscle cell we have something called myofiber. It's very difficult to understand. I know it's very difficult to grasp it. So I made a project, and I'm going to put that project for you, so to make it little more easy understanding that. Imagine, PVC pipe in a house, PVC pipe where water comes in your bathroom, uh, in your kitchen, water comes from PVC pipe. Let's consider this PVC pipe is a muscle. It's a whole muscle, like a muscle or any muscle. Just imagine this PVC pipe is a muscle, and I cut that. That's a muscle, and I just cut it. I just cut cross section it. Now I will get something like this. Something like cross section will be like this. So this is a muscle which I have cut in a cross section. Now when I cut this in the cross section, PVC pipe look empty, but in a muscle, if you see, it looks something like this. There are smaller units inside this, with yellow and the white, the pink and the blue one, sorry, the white one are the blood vessels or the lymphatic drainage or whatever it is. But the major things you can see, round, smaller units you can see inside that. That is called the muscle fiber. So each muscle is a bundle of muscle fibers collected well enclosed together, like this is a muscle. So each muscle has got muscle fibers inside that. Now let me take one muscle fiber out. Among this, let me take one muscle fiber outside. What is that muscle fiber is made up of? That muscle fiber, one muscle fiber, I'm taking it out. That muscle fiber in turn consists of cylindrical bands. In turn consists of multiple cylindrical bands. What is that? Like this. Each muscle fiber with in turn consists of multiple cylindrical bands like this, which are packed again inside. Each muscle fiber is there. Now, one fiber, one multiple filaments that is present, I'm taking it out. One multiple filament that is present, I'm taking it out. And that one filament is called myofibril. So each muscle cell consists of multiple myofibrils, which are again packed like this. And I have taken one myofibril, one filament out. That is called myofibril. So if you see this, there is a muscle bundle, big muscle, like a thigh muscle or whatever muscle is there, which in turn consists of multiple fibers packed together. And each fiber, then multiple fibers are packed together. Then you can have each fiber, you can take out each fiber. Inside each fiber, there is a filament called myofibril is there. This is the way any muscle, skeletal muscle, is made up of. Muscles are there, which is consist of muscle fibers, which are multiple inside that, and each muscle fiber has got muscle cell, which is again cylindrical, a long cylindrical one with a nuclei. All those things are there, and inside each cell is further made up of myofibrils. This is the basic anatomy or structure of a muscle there. This is what is you are seeing there, a muscle which has got bundles called fascicle. You call a bundle of a muscle called fascicles, which has got muscle fibers are there. Inside each fiber, there are multiple muscle cells are there. Fibers are there, which is in turn made of myofibrils are there. That's it. That's the way it is arranged there. I hope you understood this. Now, the last one, the myofibril, is very important for us to understand. What is that myofibril? That myofibril, I'm not going into physiology of it. A myofibril has got the structural and functional unit of a muscle. Just understand that the structural and functional unit of a muscle is inside that myofibril, and we call it as a sarcomere. Okay, sarcomere, which contains actin and fibrin filaments. That's it. Just so thick and thin bands are there, which contain actin and thin myofilaments are there. That's all you need. So a myofibril, inside a myofibril contains a sarcomere, which is a structural and functional unit of a muscle. This is the guy that allows the muscle to contract and to relax. Contract and relax. That's it, which in turn consists of a thin filament and a thick filament like actin and myosin. That's all. You can read more about it. This is purely clinical based I'm talking, not the physiology part I'm talking here. So this, the structural and the functional unit of a myofibril is a sarcomere. This guy has to contract, relax, contract and relax, has to be done there. So that's the myofilaments which we are talking about it. So how does a muscle contract now? Now coming to the point, if I am contracting, how does a muscle contract now? That means the structural and the functional unit called sarcomere has to contract and relax. Contract and relax. He has to do this movement, some kind of movement they have to do. They are in this position, they relax, or they relax, then contract, relax and contract. They have to do that. That's how a muscle allow the hand to go inside. If I want to close the mouth, the muscles which are supposed to close the mouth, elevate the mandible, has to do this function. And
The sarcomere shortens from both sides when actin filaments slide along the myosin filaments.
So what this say that the actin and the myosin, which have to slide across each other, which is the sarcomere. They have to slide each other so that you can contact them. Sliding and so what
cross bridges of the myosin filaments attach to the actin filaments and exert force on them to move. This action is known as the sliding filament mechanism of muscle contraction.
So again,
cross bridges of the myosin filaments attach to the actin filaments and exert force on them to move. This action is known as the sliding filament mechanism of muscle contraction.
So actin and myosin, they are together and they act on each other to produce the sliding mechanism, and that's how we contract the muscle. That's the action of the muscle. That's a physiology. That's too much to go into that because we have this session. I'm just running faster in that, but that is a basic thing that is happening. Now, why I'm saying this is there is a clinical relevance that is going to come. Very important clinical relevance that is going to come. That's why I explain a little more. Can anybody come to the chat box and tell me what is, do you see this? Can you come to the chat box and tell me? This is a histological picture. You can see in a Viva, you might have gone and see, and you're seeing to the microscope, you are seeing it. What you see is, can anybody come in the chat box and tell that? Adipose tissue, adipose tissue, adipose tissue. Let me see who can answer this. I can give it 10 more seconds. Okay. There is one person, I think she's, so many answers are coming, I can't. Okay, Rahman, Suhana Rahman. Okay, Dr. Suhana Rahman has answered it correctly. Skeletal muscle in a histological picture. Skeletal muscle in the histological picture. Do you know, in my times, it was so difficult to understand. So many histology and embryological slides were there. So in this, it was very difficult. I always relate this to this, you know, something like this paddy field with roads in between, and houses in between. That house is your blood vessels. The roads are the connective tissue. And if any man or anybody is there, that's the nuclei. I used to relate this that to identify a skeletal muscle in the histological session. So this is a histological session of the skeletal muscle where those muscle bundle is there, which is separated by the connective tissue, and inside you can see the light and dark bands of the actin and the myofilament, all those arrangement which I told us. So what have we covered till now? We covered skeletal muscle, which is our striated and voluntary action, fast twitch muscle there, type 1. Macroscopic structure, told you how much it is made up of. Sliding mechanism, how the muscle contracts because of the actin and the myosin slides with the mechanism which we showed you the video. That's why. And histologically, how does it appear? Fine. Dr. Joby, why have to tell for this clinical understanding? Next session is on clinical understanding, and this will give you an idea. Okay, that's what is really happening when a patient comes with an atypical pain. What is happening there? Why that pain in that area is there? When a patient comes with a referred pain, oh my God, what am I going to do? How will I diagnose this is a referred pain or not? This basic explanation of the histology or the ultrasonic structure, which I told you, will help you. So a quiz for all of you to just make sure you're not sleeping, okay? So a quiz for all of you. How many facial muscles do we have? As a human being, how many facial muscles do we have? The options are, is it 56? Is it 53? Is it 40? Is it 43? Is it 48? What is the answer? Let me see who has answered it. Great. The first person who has, oh my God, you're very good. Anusri S. Shanai. Okay, 857, 837, she has answered correctly. It is 43. Yes, the total number of facial muscles are 43. Okay, 43 facial muscles we have. We dentists are really dealing with 43 muscles only on the face. But there are additional. I will ask that question. There is one more question, catchy question that's going to come. Let's see, and the end towards the end. So we learned about muscle now. Now coming to the clinical part, function of the muscle. Now that is very important for dentists. We are giving dentures, we are giving multiple long span bridges, we are giving single tooth bridges or single tooth crowns, we are giving composite restorations, we are giving amazing laminates, veneers, we are giving. What is the role? I'm going to discuss now from this. What is the role of this muscle in this kind of thing? Is there is any role? Just listen to this session. You will understand more deeply into the importance or application of this in the clinical practice. So what are the functions of a muscle? What does the muscle helps to do? It helps to close the mandible, to chew the mandible, to do the movements like phonation or whatever. It helps. You all know that is a function of the muscles of mastication. Mastication. So it has to help in mastication. Close the mandible, move the mandible right, left, front, back to do the problem of mastication. It do that. So normally, if it does, it is fine. It doesn't have any problem if it does that function normally. Now, what happens if it over exerts, over function it does? What happens? You start tomorrow onwards, you go to a gym and suddenly start lifting weight. What happens to your muscles tomorrow? Tomorrow morning, you can see that day you may not find anything. The next day morning, you can see you can't lift the hand. You will walk like this. You can't even bend. You can't even turn. You might feel like that. That means you work, but your muscle overworked. That is what general thing. What about dental? You yawn too much. I yawn too much. Open the mouth. You stretch the muscle too much. You had a food which you have to chew and chew because it was not well cooked, or it was a hard thing. You have to chew and chew. Again, the muscles of mastication had to overwork there. Or in the night, you clench the teeth. Full night, you just clench the teeth. You had the problem of clenching the teeth. What happened? Entire night, your muscle overworked. So what happens if it works over? Normal thing I told you, it contracts, it relax, it contracts, it relax. That's all it has to be. It's a sliding mechanism. It slides inside, comes outside. It has to come. Slides inside, slide out. That's it. Done. No problem. But now here, you overworked it. You stretched it too much. You pushed it too much. You stretched it too much. You pushed it too much. Contraction, too much of contraction, too much of stretching you had because you overworked. What happens there? In a masticatory muscles, if you do that, like a paroxysm, about night grinding, you yawn too much, you laugh too much, you had a food where you have to chew too much. What will happen? I hope it's 8:40. You are not in this status now. You're not feeling like sleeping. I hope. Can I get a thumbs up, please? I'm talking to computer. That's why. Can I get a thumbs up that I am going clear? You understanding the points which I'm telling clear or not? Please tell that. Thank you so much. I can say, oh, thank you so much. So we have overworked with our muscles of mastication. So what happens there? What happens when we overwork with the muscles of mastication? Let's see that. Increased functioning load if you apply, what happens into the muscles? The muscles will get something called trigger points. That's a very basic. Muscles will get something called trigger point. That is why when you stretch too much for a muscle, or a gym or anything, the next day you get pain because multiple trigger points are already there. And these trigger points will release by itself. So some trigger points are already created onto that muscles. You have to understand that. So it's like, as I told you, the muscle is like a rubber band. You stretched it, you overstretched it, the muscle. This overstretching causes something called a trigger points in a muscle, and you can have multiple trigger points. I know you didn't understand what is trigger point, how it is created, I know, but the reason for this trigger point to be formed in a muscle is like overload or overworking, overstretching. At least that which you understood, right? So that creates something called trigger points. Now I will tell what is trigger points there. So trigger points in a muscle is being formed. Now, what is that trigger point is one thing that we are going to listen very carefully. So there is something that is trigger point is formed. Now, what is the trigger point? Is something like a muscles when it get overstretched, there is some kind of nodule will form in the center of the muscle. Just understand that some kind of nodule will form. What is that? Like a knot. In a rubber band, when you stretch, a knot forms that restricts the further pulling of the rubber band. A knot, if you put in the rubber band, that prevents the further pulling of the rubber band. So some kind of knot will form in that muscle fiber. You remember muscle fiber? I told you muscle fiber. Some in the center, some kind of knot will form in the center, and the side gets stretched. Try to stretch, make the things more fiber. So that is called the trigger point in a muscle fiber. One trigger point will make. So just listen to this. You will understand this video. Then you can get clearly what is that trigger points. Let's listen to this video.
A trigger point is a small muscle contraction which can be felt as a small nodule. Pushing on this nodule is very painful. Trigger points can exist in each muscle of the body. Multiple can exist at the same time. Often both sides of the body are affected equally. The trigger point keeps the muscle tight and weak, restricting the muscle's range of motion.
So you can have
A trigger point can actively.
Trigger points are nodule-like swelling that is seen in a muscle, and it can be felt anywhere, any part of the body. Striated muscles are there. You can get these trigger points, and you can feel this trigger point because they are superficially placed. You can actually feel those trigger points if carefully examined. And if you touch this trigger point, they can be very painful there. So how these trigger points are formed? You all know striated muscles. Muscles are attached to the bone with the help of a tendon. So this is a normal muscle. It is attached. And if you do an action, the muscle gets stretched. When you do an action, the muscle gets stretched. This is a rest position. The muscle is there. It's attached onto the muscles. That is the skeleton. To insertion and origin. Dr. Bino yesterday said insertion and origin. It is inserted at one point and origin into one point. So when they do that motion, it gets stretched. Action comes, it gets stretched. and it comes back normal, it gets stretched. That's normal thing that happens. When it is overstretched, when the muscles are overstretched, what happens at the center of that muscle, a knot like thing that forms. I'll show you the video, you'll understand. A knot like thing that forms. That actin and myosin at the center, which is supposed to slide, doesn't slide. The sarcomere, which is a functional unit, get closed and packed together. It doesn't, it get compressed, but it doesn't get stretched. It get compressed, but it doesn't get stretched, doesn't go back to its original form there. That happens in a muscle filament there. And what happens when that happens? The ends of the filaments or the muscle fiber get more tense. Too much of pressure. That pulls the periosteum. That pulls the periosteum and causes pain there. So a single muscle fiber get overstretched onto the sides because center is compressed there. It cannot go back into the original length. How they are compensating that original length? The side, the original insertion area, they get stretched and they somehow compensate it. But that causes overstretching or pulling of the periosteum, which causes pain there. So that is called a taut band, a muscle fiber which is overstretched. Why it is overstretched? The center, it is compressed there. The sarcomeres in the center, the functional unit are compressed. It is not getting relaxed. The sliding mechanism is not taking place at that point there. One fiber is okay, but multiple fibers. One fiber is okay. You smiled, nothing. Nobody's going to bother. But multiple fibers get overstretched. It forms something called trigger zone or trigger point. That area is very painful. That area you touch, it will be painful there, severe pain, because many fibers have become that. So if you see this diagram, you can clearly see that the contracted sarcomeres, which is supposed to relax, have not relaxed. They are all adhered together. You can see the loss of striation also. It lost its striation also in that center. Surrounding it is okay, but that area it lost its striation also. The light and dark, they are all compressed together, and surrounding fibers are compensated by stretching it. Let's listen to this video now.
Let's take a closer look at the trigger point. A trigger point lies in a taut band. The taut band is a tight strand of muscle that feels like a cord, easily mistaken for a tendon. The trigger point itself can be felt with the fingertips when its location is superficial. The size varies from a pinhead to a pea. When we continue to zoom in, we can see the muscle fibers that make up the muscle. The lines on the muscle fibers represent sarcomeres. Millions of sarcomeres, acting like tiny pumps, have to contract to create movement. Sarcomeres can become overstimulated and unable to release their contracted state. This knot of contracted sarcomeres shows a segment of the fiber that has become shorter and wider because of this. But also a different segment now becomes stretched by this tension, shown by the greater distance between the sarcomeres. Together, multiple of these sarcomere knots form the trigger point. The stretched segments of the fibers give tightness to the taut band in which the trigger point lies. When sarcomeres are stuck in contraction, blood flow stops in the immediate area. The resulting oxygen starvation and accumulation of waste products irritate the trigger point. The trigger point responds by sending out pain signals.
So this is what happens in overstretching of the muscle. So the trigger points formed with the contraction of the sarcomere, which doesn't go back, and this other part of the band overstretched. When it overstretches, it contracts the blood vessels in the surrounding area. Compression of the blood vessel happens, so there is no blood going in and out. Pooling of the blood happens. So oxyhemoglobin pools there, and that causes severe pain in that area. So pain is generated without any reason also. Imagine no reason, nothing. You did not poke it, you did not touch it also, still pain will start. So the reason of that pain, a patient says that for no other reason, but pain persists, lingers, comes and goes without anything, is because of these trigger points that are present in some of the muscle, and they are auto-generated. Why? Because of the reason, because of the presence of that trigger point. I hope you understood that. So trigger points and referred pain. So trigger points can generate pain If you touch it, you can generate pain. Even if you don't touch it also, it can cause pain, which is equivalent to the dental pain because we are dealing with the dental. Now, the problem is referred pain. What do you mean by this referred pain? So that's another important two more three slides you have to understand this referred pain. So one of the most difficult thing to make people understand what is this referred pain. So I'm trying my level best to make you understand what is referred pain, and the trigger points usually generate referred pain. Why? We will discuss that. So this pain, which is being trigger point, is present in the muscle called temporalis. It is present in the temporalis there. But the pain the patient is feeling not in that area. Patient is feeling a temporal headache. Patient is coming headache. In today morning when I got it is headache and there around the eyes I got pain, and after some time the pain I get pain in the maxillary sinus area, the maxillary first molar, second molar or premolar area, dull aching pain. I feel like poking, I feel like pressing. That kind of discomfort I started getting. This is what patient says. Okay, how we have to understand that this is something that has happened in a muscle which is far distant, but patient is feeling that pain of that trigger zone in somewhere else. That is the referred pain. Patient feeling the pain somewhere else. To make it understand, let's go for a journey. Let's see that I am walking on a road alone. I'm walking on a road alone, enjoying the scenery and walking alone. Suddenly, I came across a junction. There's a junction in front of me. I have to cross the junction, but I know where I have to go. My destiny, I know where I have to go. So I have to cross the junction and I have to go into my destiny. I know my place. As I am traveling, as I'm going towards the junction, there is somebody else is coming towards the junction from the other side of the road. Okay, fine. He's also coming. Then one more person is coming from other side. So multiple people are coming, and all have to come into this junction, this area, and they have to cross each other. And I have to go into my destiny. He has to go into his destiny. This person has to go into this. Yeah, that's it. They have to cross over, or they have to converge at one point, and then they have to continue the journey. So while they're converging, if I know that person, hi, how are you? I will communicate with them. I will put a tap on him. I'll tell, how are you? I'm fine, fine. How is everything is fine? Some kind of communication I will make with that person if I know that person. If I do not know the person, if it's too busy, I can bombard with him. I just might hit, he might hit, just like that. It's a very narrow area. You can get bombarded or you can hit like that. You can get communicated with each other and we will continue the journey. So this area, the center area is the area where we converge, and I take my path, he take his path, but we just communicate and go and continue the journey. Now that area is the area where we converge. Now, this is a simple example I told you. Imagine you are getting a pain, dental pain. Okay, pain is coming from there. If you have a pain from a tooth, the pain from the tooth is carried by some nerve, your trigeminal, your mandibular or maxillary. So the maxillary area, the maxillary nerve is carrying the nerve from the tooth. The nerve carries the tooth, the pain, it goes into the spinal cord where there is a junction there. And the nerve that carries, it's called the first order neuron nerve. It's called first order, first order neuron, which carries the pain from the source. What is the source? The tooth, the maxillary area, maxillary tooth, from the periodontium. It carries it, it goes into the spinal cord, and that nerve is called the first order neuron. It goes into the spinal cord. What happens in the spinal cord? There's a junction. It crosses over. It has to cross the junction to the other side. Right side has to cross the left side has to cross the right side. That's it. So that's a normal way. And that is called the second order neuron. It goes into the thalamus. A part of the brain it goes. And from there it goes into the cortex, which is represented there. If it is tongue, it is represented in one part. If it is tooth, it is represented in part. Anterior tooth, posterior tooth, like that, it is represented in the cortex in different parts. So pain from that area or sensation from that area has to go into that part of the cortex which identifies it. This is the normal pain pathway that happens. Like that guy who want to travel, he want to cross the junction and he want to go into that area where his destiny normally going. But the problem is head and neck has got, and the last one is called third order neuron. The head and neck has got so much muscles are there. There is muscle, even tongue, Dr. Binu took how many muscles, how many nerves for tongue itself are there? Four. So muscles of mastication, muscles of facial expression, sensory innervation, motor innervation, special sensation. So you can imagine this all has to go through this junction. It has to cross this junction onto the other side and then go up. All has to cross. So while they were crossing, they bombard. They might say, "Hi, I will take this message." He will take it. "I will take this message. I will help you." They try to help each other. That junction, that is called the convergence theory. It's called convergence theory of Rutherford Page. Because of this crossovering of this one, the brain get confused from where the hell it has come. Is it come from the tooth? Is it come from the periodontium? Is it come from the muscles? Is it come from the tongue or the special? The entire thing gets messed up. It get confused. So, okay, it came through this nerve, so I will put it on that area. So actually, the pain is on a muscle surrounding it, which is coming through, got bombarded in the junction, what mixed cortex get represented in a confused way. It says that it is from tooth. So it will tell that particular tooth area, it will pop the pain. Pain is there at that area. But really pain is somewhere else. Patients, we have to identify. Patient also doesn't feel it. Patient feels from only that area. From patient perspective, that molar teeth only is patient has done pain. Other area, no problem. We have not checked it also. We have not checked it also. So that is what is called the referred pain. So I explained the one of the most difficult part called referred pain happens in the muscles of mastication because we have interconnected. So much nerves are there which get angled at one area called spinal cord. It has to go to that spinal cord. You can see all have to go to that spinal cord and get converged from right to left and then goes into the brain. So that is the reason for that reason of that referred pain. So that is why we dentists are not very thorough with it. Whenever pain comes, we always see the tooth. We sometimes even root canal for a tooth which is not even caries lesion is there. Assuming a small bony loss, we thought, oh, it is a endoperio, and do a root canal for that crown for that still pain says the pain, patient says the pain is still persistent. Sometimes we extract the tooth. Let us forget about it. But there was another problem happening there. Even after extraction, also patients come back to us, say that even after done that, I don't have any release. Same thing happening there. Patient gets fed up. No doctor can identify it. I went to multiple dentists, neurologists, I went. So many things. Scans I've done. I did the MRI, CBCT, whatever thing doctor said I did, but still the pain persists. There are situations, there are conditions which happen in our practice there. But simple identification of this referred pain and the reason was the surrounding muscles would have saved the patient and simple methodology is available. So what did I cover here? I covered a very important general dental practice topic called trigger points, which you do not know what it is actually. A muscle has got a trigger point and how they are formed, I explained you, and referred pain. It's one thing which I have explained to you, and why this referred pain happening. Sight is somewhere, but pain is somewhere. Why this confusion is happening? Also, I explained. You know about cardiac pain, right? It is referred onto the lower border of the mandible of the left arm. Why? Heart is somewhere else. The pain is again at somewhere else. So why does that happen? Gastric pain, exactly the same thing. It happens, it's referred to somewhere else. And we think that is heart attack. When we go and do a checkup, no problem, that BP is nice, everything is normal. When you give a gas trouble, a Rantac 150 you give, pain is gone. You're released. So this is referred pain, which you need to know about it. So come on, guys, one simple quiz I told you. One simple quiz. Come to chat box to make yourself active. Come to chat box and tell me which among the facial muscle inserts into another facial muscle. Which among the facial muscle inserts into another facial muscle. Now, my choices are temporalis, masseter, Binu will kill you. Sternocleidomastoid, buccinator, medial pterygoid. Which among the muscle is attached to another? Great, 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 great. Okay, okay. Oh, great. That's good. That's good. Deepak Singh. Deepak Singh is the first one who has answered it. At 9 p.m., he has answered it. And the answer is buccinator or D. Good. Buccinator and the muscles of facial expression, but an important muscle with respect to temporomandibular disorder or bruxism. When we talk about it, this muscle cannot be avoided by dentists. You need to learn more about this muscle there. That's good. That's good. You are listening. Now, next, the buccinator is the answer. I hope I am not talking blah blah blah. I hope I am with you. Can you just give me a thumbs up and say that okay? Can I continue to the clinical session of the last 15-20 minutes are there? Is the muscle exercises or can I continue? Are you okay? Please come on the chat box. Tell okay, I'm okay, fine. Okay, great. Thank you so much. I'm not talking to my laptop. I'm talking to human beings and listening to human beings. Thank you so much. Thank you so much, Dr. Nasir, Dr. Srivastav, Dr. Everybody who has opened the video. Thank you so much. Next session is very important because I'm going to do some gimmicks here. If you want to be with me to see some exercises, there are so many exercises are there. Some exercises, some identification of the muscles. If you can do, it will be good. Okay. So that is done. Yes, we are going into now. We have done the importance of this. If I directly started this palpation of the muscles and mastication, you would have said, oh, Dr. Jovi showed so many videos. You showed this was nice. It was so interesting. But finally, why did I do this? Why did I find out that muscles? You will ask that question, why, why? But now I have covered why do we have to palpate a muscle, why we have to identify the trigger zone, and then I can easily explain you the muscle exercises. So easy now if you would understand that trigger zones are there, which are the area it is there, you can easily do that. So let's see the palpation of two common muscles I'm going to discuss now. Two very important muscles you can't miss in your private practice are there. So we need somebody to guide you to do this palpation. It is not a job. We need somebody to come. So I am asking somebody to come into this room platform and he is going to demonstrate professional person, excellent person, a good masculine person is going to come. He's a trainer, he's a fighter, he is renowned world over the world, internationally known. If you might be a fan of him also, so I'm going to invite that superstar into the platform and he's going to demonstrate how to palpate the muscles of mastication. And other than He-Man. Okay, he is none other than our He-Man. So he is going to come, every slide he is going to come and he is going to demonstrate the muscles of palpation of each muscles of mastication there. So this is He-Man skull. Okay, this is the skull of He-Man, where the muscle, one muscles of mastication, which we are going to discuss, is the temporalis muscle. You can see the He-Man skull and the temporalis muscle. But how this muscle will look in front of a real He-Man where he has got soft tissues and all that? Let's see the real He-Man. He's a real He-Man. And oh my God, who is this real He-Man? He's a real He-Man and he has the muscles with all the hair and everything. Where will be the temporalis muscle on his real face? Let's see that. So temporalis muscle is inserted onto the coronoid fossa or coronoid fossas of the mandible, that coronoid fossas of the mandible, and onto the temporal fossa. As Dr. Blue covered, I'm not going into detail about that. So this is inside that fascia, that muscle is running like this. Okay, so this muscle is running like this. And what does this muscle does? This muscle helps to elevate the mandible, which is depressed, it elevates. Which fibers of the muscle? The anteriorly vertically aligned fibers. There are three types of fibers which are oriented in temporalis. The vertically oriented fibers of the temporalis help the mandible to go up. What about the middle and the posterior, the obliquely arranged? It helps to pull the protruded mandible, bring the mandible back. So two functions of temporalis is it elevates the mandible, that is the vertically oriented anterior fibers helps it that. The middle and the posterior obliquely arranged fibers of the temporalis help to retract the mandible, which is protruded, retract the mandible. Very important muscle which we need to know. So that is the temporalis muscle function. The vertically oriented, the middle and obliquely oriented fibers. Its functions are different for temporalis. That is that. Now, how to palpate this muscle? We have to palpate this muscle in a clinical situation. How we have to do that? Temporalis palpation. Okay. So again, I told you our key man has come. Key man is going to demonstrate you how to palpate temporalis. So what you need to do is you need to take the thumb. You can, I have spotlighted, the spotlight is there. You can listen to my video. You have to get the thumb. Thumb has to be kept at the maxillary prominence. You know, the zygomatic arch goes like this, the maxillary prominence. You can feel the maxilla, the thumb. Just keep the thumb at the maxillary eminence or maxillary prominence. You keep the thumb there, and one finger breadth above. One finger, you can see one finger above, you hold it. One finger above. So how I did this? I first palpated, I found out the maxillary eminence. Then I kept the finger like this, one finger breadth, like this, one finger breadth above, above. I rotated it above. Now just bite yourself and see. Just bite, open your mandible and bite yourself. You can see there's a movement. Can you feel that movement? Can you see junction movement there? Can you see junction movement there? Anybody? So the mandible, the coronoid process of the mandible is opening and closing. You can feel that. So let's see how it is done. The maxillary prominence, one finger above, one finger above, hold it there. And then what you do, open and close. Okay. While you have to go back, you open and close. One finger, you all the way, you go back, you get the temporalis there. And all what you see is the temporalis muscle. All what you see is the temporalis muscle. From there, whatever you see is the temporalis muscle. Now, what all you have to do is, so one finger above you keep it all the way, you just close the mouth, open and close the mouth. You can see pouncing, you can feel the pouncing of your finger. You can see the pouncing of the finger. That means the temporalis muscle is opening and closing. You have to open, then temporalis will take the mandible off. That time you can see the pouncing of the temporalis muscles, we can see, especially on the anterior segment. You can protrude it out and you can take it back. You can see the posterior area. You can see there is pouncing of the muscle. So that is how you palpate temporalis muscle. Stand side of the patient. I feel the maxillary eminence, one finger above, hold it, and ask the patient to open and close the mouth. You can see the pouncing feel in the hand. Just run all the way around above your earlobe, just go all the way and ask the patient to close the mandible, open the mandible and close the mandible. You can feel on both sides, you can see the temporalis muscle is acting and you can see the pouncing of the hand. So you just, that's a palpation of the temporalis is done. Just show it again. The palpation of the temporalis is done. Hold it above and just run all the way back above the earlobe, you can see, and then press it, and you can ask the patient to open open and close the mandible, open and close the mandible. You can see the pouncing, you can feel that pouncing in your hand, and temporalis can be really felt while doing that moment. One point you can't see any pouncing, that means temporalis is over. After that, no temporalis insertion you can see. And you can see the picture how it is done. So that is done. Now the trigger zones in the temporalis muscle. So this is how you palpate the temporalis. Now what are the trigger zones that is present in the temporalis? The temporalis muscle has got 4 trigger zones are there in the temporalis there. Total 4 trigger zones are there in this fan-shaped muscle. 1, 2, 3, 4 in the order from anterior to the posterior. 1, 2, 3, and 4 trigger zones are there. You know the trigger zones, like thought band, the zone which is present will be there. 4 trigger zones are there. The trigger zone 1 referred pain. If there is a trigger zone that is present in the one segment, if it is present, the pain will be referred on to the more anterior teeth till the first premolar. The pain can be referred from the anterior teeth to the first premolar. The pain can be referred. Patient might feel pain in this area or the premolar area, or it can also get referred on to the frontal area around the eyeball. face, patient can have pain. Or on the anterior part of the temporal bone also, patient can have pain. So 3 area patient can get pain due to the formation of trigger zone in one of temporal bone. 3 area patient can say. In two, trigger zone 2, if the patient has got pain, if the patient can get pain onto the premolar and the first molar up to the second molar area, patient can, from the premolar to the second molar area, patient can have pain, or the posterior part of the maxillary arch, patient can complain of pain, and also onto the almost middle part of the temporal bone, patient can have pain. Here, patient can get pain. Sometimes you press it, you can get pain here in this area, pain you can get because of the temporalis muscle trigger zones in two. The third, it's on the posterior auricular area. In the occipital area, you can get pain in 3, and for the back of the head, you can get pain because of that. So dentist concern is 1 and 2 area. You can get referred pain, which is closely related to the tooth and also on the temporal bone. So if you see in the clinical situation, if you see patient complains of pain in the anterior segment of the teeth, anterior arch, and around the eyeball and onto the temporal bone. In zone 2, trigger zone 2, patient can get pain on the posterior part of the maxillary arch and onto the middle of the temporal bone. And 3 and 4 on the occipital area, the patient can get pain there if there are trigger zones present in a temporalis muscle there. So usually clinical history, if you say, ask the patient tension headache, patient might say, yes, I get when I get in the morning, when I have a lot of things have to be done. If I not I get good tension, I can get full around the eyes, I can get an aura of pain happening around my eyes. Referred pain on the teeth could be one of the reason there. So this is something called myofascial pain dysfunction syndrome, beginning of some disease, a greater perspective which is not related to tooth. No way the tooth comes here, or myofascial pain dysfunction syndrome happens there. So that same patient who told me, 32-year-old patient who told me had a pain and no other things I can elicit onto that patient by IOPA, by OPG, everything is good. When I asked the history, she was a bank cashier and long continuous hours with tension, and posture of her was not good. She has to sit in a posture which is not suitable for her, and she get neck pain, she get pain on this area, all those things was there. High tension job because she is in the peak of the cashier, you can't even put one paise difference. So highly tension job, and clenching with the mouth was there. So all those things was there. So the real problem for her when we palpated the temporalis, she get that pain when we palpated the temporalis. So it was a myofascial pain dysfunction syndrome in the beginning stage, not in the end stage. Beginning stage it was there. So the trigger point temporalis muscle can cause tension kind of headache and maxillary toothache. For dentists, we should know. So pain exerts over the temporal region, over the eyebrow, upper teeth, and occasionally to the maxilla and even to the TMJ. Very rarely. Chronic case only it goes into TMJ. It doesn't affect TMJ much, but it can extend onto the surrounding areas of the TMJ. Patient on kind of the classical sign is referred pain, tenderness, and hypersensitivity to the upper teeth to hot, cold, and pressure. Upper teeth to hot, cold, and pressure is a classical sign. Patients rarely complains of rusting. No opening the mouth, patient never say in an initial or beginning stage, patient never says or the difference in opening the mouth is there. So tension, headache, referred pain from teeth due to hot, cold, or biting. Pressure means biting. Patient bite hard thing, patient gets pain there. So that is the classical sign of TMJ, temporomandibular trigger point stimulation pain is there. And the causative reason for this is excessive forward posture of the patient. Even dentists who's bending forward for a long period of time can get this kind of pain because of your posture is not good. Overuse of muscles like chewing gums, excessive use of chewing gums, jaw clenching, or bruxism in the night, nocturnal bruxism or full-time bruxers can get this. And chronic use of anterior displays. In a patient had a once that happened is one patient had this lock jaw, the dislocation, mandibular dislocation while yawning it happened. But this patient only put it back. Somehow she put it back to the normal and she was happy. But next day onwards, for 3 to 6 months she's having severe pain because it was not properly displaced there. So she started using because she can open the mouth, not to the full extent she was not any other problem. She started continuously. But after 6 to 7 months, she gets severe pain. And that was a chronic overuse of an anteriorly displaced temporal which has happened. She did not know. Direct trauma to the muscle. Very instance, let me tell you, there is one patient who was in the field and somebody was plucking coconut. You know, coconut, he was plucking the coconut. So the coconut fell down, but it went and hit the land and came and hit on his right side. It came and hit on his right side. He had some kind of feeling, but next day morning when he started opening the mouth, he could hear the ringing sound was there. So when we checked, it was a combined problem with the temporalis muscle of the opposite side and the one muscle which I'm going to talk next, the pterygoid muscle which we talked. So there can be a problem which you think it is very simple. The history is very important, whether the patient had any trauma. Maybe the patient turned their head and went and hit onto a bar or somewhere it may hit. That can itself can cause a trigger point in that area and patient is not aware about it and can cause pain later. So secondary trigger points like sternocleidomastoid and the trapezius muscle, the neck muscles. If you want to learn more about it, please attend next Monday's TMD lecture by Dr. Deepak Deryani. Do not miss that lecture. Deepak Deryani's lecture on TMD. A must attend lecture there. So he's going to explain more about the neck and other muscles and its referred pain which is been felt onto our teeth and perioral region there. What is this? Now, you know, many times when you use the earphone, headphones, many times you want to see that song or that lecture, you want to take that headphone, you can see this tangle like this, like this. Oh, and it's so difficult and irritating to release that. And finally, you might throw it down. And nowadays, your earphone has come. So it is so comforting. It is now, you don't need this guy now. You get fed up and you throw it away. Releasing that it is very difficult. Now here the same thing, releasing a muscle which has got knots or trigger zone, trigger points which are tightened like this, tangled like this. You can release it, you can unrelease it, you can make it normal without doing any drug therapy. You can do that. That is called trigger point releasing. Releasing the trigger point so that you can do all the function without any pain or discomfort. You can do that. That's called trigger point release. That's next session is how to release the trigger point for temporalis muscle. Most important thing that you need to listen to this man is Cesar Millan is a famous dog trainer. Any dog which has been abused by somebody, whose leg is fractured, who's been tortured by somebody, or behaviorally the dog is very mad at human or not. You cannot domesticate that. You give to this guy. This guy will train the dog. Whatever situation it is, he will train. He's in Italy and he's a famous trainer in Hollywood movies. You know, many Hollywood movies you might have seen where animals have been used and he can speak to the animal. Now, what he said is, whatever conditioned animal you brought into me, I can train him, but there is something called gradual conditioning is required. Now, this is something which I want to tell you that myofascial pain dysfunction syndrome is least understood by us. There is a hidden psychological problem for most of the patient who is undergoing myofascial pain dysfunction syndrome. Just like your trigeminal neuralgia, the maximum number of suicide cases is because of that trigeminal neuralgia in dentistry to see, because unbearable, nobody can treat. Whatever treatment you do, it appears back. Exactly the same way, here I want to tell you one thing, that this thing have got a psychological impact. So you need to talk to the patient, understand them before doing any kind of next phase, which I'm going to tell. Muscle exercises will tremendous relief, but a step before that is talk to the patient, and that psychological approach is very important, followed by the next phase, which I told you, muscle massaging or exercises are good. And finally, pharmacotherapy can be done. if you do not treat it properly. Initially, patient might be comfortable, may release, but it can adverse the situation also. That is the rude way of doing massaging. So if you don't do the massage therapy properly, let me tell you, your patient will be ending up and sitting in somewhere with neck cannot be turned, it cannot be lifted, mouth cannot be closed or opened. It's not Dr. Joby who said to do it and do it for all the patients, which I have told you very clearly. You have to take precautions, and I told you have to talk with the patient if you find the muscle trigger points are being generated. What is the reason? There can be a fight in the family happened. A husband hit or a wife hit or a child, son hit the mother. So many things are there. So many things pushed when and fell. It was for fun or it was really there is a fight that happened. Nobody will come and tell my husband pulled me or my wife did that to me and that's what happened. This nobody is going to tell you that. So there can be history behind that. And you need to understand that nobody will reveal that. That's very important to identify that while treating this situation. So we have a good session coming on Monday. Do not miss that. All these things will be detailed there. So temporalis muscle trigger point, how can you release this that? And I'm calling none other than Shaktiman, the cartoon of my time when I used to see Shaktiman. Sir is going to come and he's going to tell us how can you relieve stress or trigger points in a temporalis muscle. You already formed. He-Man has told you there is a trigger point in the temporalis and what will thing happen. Now he is going to relieve those trigger points in a temporalis muscle. So I'm going to show you one important exercises which can be recommended to your patient for temporalis trigger points that is present there. So this is your Shaktiman. So Shaktiman has come and he is going to tell you how you can relieve temporalis trigger point. So you have identified temporalis muscle. I hope you know the temporalis muscle now. By the now you know the temporalis muscle's origin and insertion where it is being there. So you know how to spot temporalis muscle. Now what you have to do is you have to massage. You have to identify the trigger points. You know 1, 2, 3 trigger points. You know, so you know which area the trigger points are there. 3 and 4 no pain, but 1 and 2 pain is there. Means that area there is trigger point is there. So you identified where it is there. So what we will do is you massage the area in a circular pattern. So you need the two fingers. The two fingers you keep that trigger point where you have identified. Teach the patient to keep that trigger point, pin spot the trigger point, keep the two fingers at the trigger point where you have identified that. And then massage it circularly, press it circularly in a circular pattern. You do it around 5 to 10 times. You do it in one cycle and then reverse it other way around. Reverse it other way around. That's how you do massaging for the temporalis. Let's see that. Let's see that massaging. Okay, for temporalis, keep the two fingers. You identified it. You identified the area where you have done your and that area. Suppose if it is in the point one area, you do it in a circular pattern in clockwise all the way to the whichever point is there. Then anti-clockwise. Can you see now it is anti-clockwise? You do it back. Okay, so you do it back onto the whichever trigger point is there. Is 1 and 2? Do it for the 1 and 2. If only one in that area, you do 1 and 2. So this has to be done minimum 3 to 5 minutes, 4 to 5 times a day. If the patient can do it, is can relieve the trigger point in a week's time. You can see the patient comfortable because the trigger points are relieved, the taut bands are relieved, and patient can do normal function there. So that is temporalis muscle trigger point release, that which I've told you, trigger point relief, which I've told you. You are just relieve the trigger point. So quiz, another quiz. How many neck muscles do we have? I've told you facial muscle. You answered it very correctly. How many neck muscles do we have? Let's see, the options are 18, 26, 31, or 49, or it's 20. Let me see the answer. How many neck muscles that we have? Oh, great, great, great. There are very good students here who are listening from the beginning. And the first answer is Gayatri. Gayatri, you are the one who, and along with that, Dr. Nasir is also said it's almost 9:25, 9:25. And Bhagya Lakshmi also has said 9:25. Bhagya Lakshmi has answered 9:25. Rizwana Khalid has answered 9:25. So many answers at 9:25. It's a fraction of time. Okay. Simran Singh or 9:25. Sheila, Dr. K. Sheila has also answered 9. So many answers 9:25 itself. So all are good winners. Thank you. Thank you so much. Yes, the answer is correct. We have 26 neck muscles are there, which are connected to mandible and the surrounding structure. They also plays an important role. And you come on Monday, you will listen from Dr. Deepak sir about the importance of the neck muscles in posture maintenance and its role in referred pain in TMJ or the myofascial pain dysfunction syndrome there. I hope you are not yawning. Give me 5 more minutes, I'm done. 5 more minutes, I'm done. A 38-year-old female patient walks into the dental clinic. She has been treated. She has seen multiple cases. Her main problem is her opening of the mouth is restricted. For the past 2 to 3 weeks, she's facing this problem of restriction of, and this is persistent. This is persistent. This is not coming down. She can only open like this, not more than this. If she opens more than this, she got severe pain. In this range motion, she don't have any pain. She moves right side, left side, no problem. She bites at this time, no problem. But bite hard, she got pain. But more than that, she can. And this is persistent. It's not decreasing anything. Nothing is there. So definitely opening the mouth. Our first view, no history of trauma, nothing is there. So first thing we'll check for your third molar. So indicated on OPG, there is an impaction in one side. There is another decay tooth, but that is not asymptomatic. There is no problem here. There's no information, no tendon percussion, nothing. She doesn't have any problem with that. So next thing will be think about the TMJ anything. So even TMJ, OPG right side and the opening and closing TMJ also OPG, you can see there is no much dislocation, no much problem. She's perfectly fine there. Then what we did is palpation. We palpated one muscle, and that the most common muscle which is involved with anything called opening the mouth is your lateral pterygoid, a muscle which you should know in depth and detail about. This is lateral pterygoid muscle. The reason is because it is attached directly onto the capsular disc and to the pterygoid fovea of the mandible. That is the reason this muscle can have a tremendous problem with TMJ diseases. So this is the muscle you should know in detail. Dr. Binu has told you about pterygoid. It has got a superior head and an inferior head. Its insertion, it acts on everything. You know, I'm not going into that, but this is a muscle that you should suspect that. And it is difficult to palpate this muscle, but it is closely related to the TMJ problem there. So I will just show you a video demonstration of a man skull, how you approach to palpate a lateral pterygoid muscle. Just listen to this video, how you have to approach intraorally to palpate lateral pterygoid. It's a little difficult. You need some hands-on kind of things in live in patient you need, but I'm trying to make it very simple. I'll show you a video of myself doing it.
Just take the jaw off for a second. So you proceed along these teeth medially, and you'll run into sort of a firm gum-like tissue, and that will be the belly of the muscle. Sometimes you can come in underneath, and you can contact the muscle this way.
So,
to access this muscle, I like to stand up, and I walk around, and then I open the jaw, and I slide my finger along the upper set of teeth, and then I proceed more medially until I run into the pterygoid, the lateral pterygoid plate, with my forefinger here. So I'll strum it or contact it. As the muscle relaxes, sometimes I'll just shift the jaw a little bit posteriorly in this direction to stretch the attachment in there. That's the lateral pterygoid muscle.
So let's see how we can do this. He-Man, he's going to explain you how the lateral pterygoid to be palpated. So it's intraorally, this approximate area it runs. You have to open the mouth of the patient, keep the finger inside or along the side of your maxillary teeth towards the sulcus, maximum towards the sulcus, and more posteriorly that you have to go from front. If you see, you have to put it inside, slightly open the mouth, all through the sulcus, buccal sulcus, all the way back towards the third molar. You have to go. It is little painful. Patient might say when you go there, when you touch on the posterior most area, when the finger goes and press it, or the patient might say pain because of the lateral pterygoid trigger points that is present there. So lateral pterygoid has got two trigger points present in the lateral pterygoid. In the superior head and the inferior head, you have trigger points. Superior head and the inferior head, you have trigger points there. And the stimulation of the trigger point can cause pain in the maxillary sinus area. Maxillary sinus area, sinusitis kind of pain if the patient can have. And second thing is in the auricular area, patient can have pain. A classical thing is patient feel like tinnitus inside the ear. Patient feel tinnitus inside the ringing kind of sound inside the ear or on the ear because of the trigger point that is present in the lateral pterygoid muscle there. So maxillary sinus, difficulty in opening the mouth, ringing sound in ear. These are the three classical, most common clinical features which the patient says with the lateral pterygoid involvement is there. So the lateral pterygoid occlusal. What are the reason for this occlusal interference? A cusp which is high points, your restoration, your crown, your bridges, which has got high points are there, which can really irritate lateral pterygoid because this is the muscle that slides the mandible back into the posture or opens there. So while it does it, if there is any interference there, this muscle it doesn't like it. He doesn't like it. He need a smooth sliding and gliding movement. So that is why it is very important in your restoration, in your crown or bridges, high points should not be there. The functional and non-functional cusp should not be interfered, should do this function smoothly there. Bruxism. Bruxism is overusage of this muscle. It can cause the pain there. Arthritis of the TMJ joint can cause pain in the lateral pterygoid there. Excessive gum chewing, again for the nail biting habit, excessive, it can cause that. Mandibular protrusion that might occur as a when playing wind instrument, like people who are playing instrument, why instruments are the musical instrument, especially like wind instruments, because of too much protrusion of the mandible, you can have. So these are the reasons we can develop pterygoid, lateral pterygoid trigger points there. Now, once you identify lateral pterygoid, how can you relieve that? So Shaktiman is going to explain to you how we can relieve lateral pterygoid trigger points. For this, you have to keep your head all the way. You should look into the sky. It's like the center of the sky you should look. First, you look up, vertically up, keep the neck stretched high up, and then what you have to do is just see again. Then you look, see the neck is stretched up, you look exactly up, the necks are stretched maximum. Okay, the necks are stretched maximum. Look, taking it back and stretched up. You ask the patient to open the mouth and bite. In the stretched position, ask the patient to open the mouth and close the mouth and do movement. Stretch up and ask the patient to do one additional thing that you can do is you ask the patient to bring the mandible forward and do it. Here I am doing it just open and closing it. If you see, first I am just opening and closing it. One additional thing is you ask the patient to protrude the mandible. You can do that also. So that is the one exercise for pterygoid trigger point release that you can do. Opening and closing the mandible by stretching the neck up. Just open and ask the patient to do multiple times, open and close the mandible. One additional thing is you can ask the patient to bring the mandible forward and then ask the patient to do opening and closing and be done. Bring the mandible forward and ask the patient to bring the and ask the forward. Bring the mandible forward maximum. Ask the patient to bring forward and do that. Opening and closing can be done. So these are the two exercises which you can do for pterygoid release. This really makes the pterygoid muscle relax there. So you can bring the mandible forward. So what are the 5 key points in massage therapy? We have to do any muscle massage therapy. You have to do posture. Keep the patient always straight. You have to keep the patient always straight. No bending forward, tilting, nothing, because you might have seen that I'm doing it always straight, stretching it up. No bending and doing it. No, in the bed, patient should not do that. He has to stand and make sure the patient stand in front of the mirror make the shoulder straight, and then do these exercises there. Trigger point has to be patient. You should teach the patient to find out the trigger point. Yes, the trigger points are done and patient is thorough with that, and then they should start applying the pressure. Now, trigger point is not a pinpoint, it is a zone. So the patient should do it a circular motion. It is not like a facial cream that you apply. You can apply Fair and Lovely cream like this. You can apply, there's no use about it. It is a pressure point, a zone. You have to apply pressure nicely in a circular motion, clockwise and anti-clockwise in a wider area, so that you can relieve and increase the blood circulation to that area. Deep breathing can really help. You should know about how to take the deep breathing exercises that can really relax the patient in between each cycle. You can tell them to do that. Heat and cold application also are good, can relieve the trigger point. Some kind of relaxation can be done depending upon the condition there. And pharmacotherapy, non-steroidal anti-inflammatory drugs can be given. Let me tell you, one of the best is your acetaminophen, paracetamol, or Neftal. Please do not give MR and spasm. That is not for striated muscles or around the muscles. That is for the cramps or other areas. Smooth muscles would be good. Simple analgesics, non-steroidal anti-inflammatory is more than enough. In a initial chronic conditions, you need to refer. You need drugs like diazepam. You need some higher end of analgesics. You need narcotic analgesic. You might require, but you need to refer that. So Monday you attend, you will clearly tell about the process of pharmacotherapy for this trigger point release will be discussed on Monday evening session by Dr. Deepak there. So initial or acute conditions, simple analgesics, acetaminophen or paracetamol or your Meftal or diclofenac, those kind of things would work better. Not combination drugs should not be tried there. So the facial pain, if you want to read more about it, read this article, Neurological and Neuro Methodology of Management of Facial Pain with related to Myofascial Pain Dysfunction Syndrome. You can read an amazing article, a beautiful way it has been explained about the psychology and management of Myofascial Pain Dysfunction Syndrome. And I told you, I'll give you the discovery that is done. So this is my table, my close friends. Still we have good friends. One person has departed from this world. Others are there together practicing successfully in all parts of India and around across the globe. They are practicing. And I am this guy who is standing there. And I am holding chorda tympanic nerve. In the dissection of deep dissection of the face, the lateral side of the face, I found out chorda tympanic nerve. I dissected and exposed it without even breaking it. Origin of how it originates from the lingual nerve, how it goes and joins the facial nerve. Entire stretch, I somehow found out. I was totally in the initial days, I was not prepared for anatomy, but due to the constant motivation of the teachers surrounding it and their guidance, finally I was able to discover this, and everyone came, even the PhD people who are doing a PhD in that time, they came and showed this chorda tympanic course, which as you see in Chaurasia, as you see in Netters, as you see in the textbook, I could dissect that and show, and I am holding that chorda tympanic with that forceps there. That's all because of my teachers and their support. Thank you so much. So we covered basic structure and function of a muscle and how the trigger points are being formed, how referred pains are being formed, how to palpate muscles, how to relieve trigger points, and temporalis and lateral pterygoid, which are closely related to the TMJ I have covered. There are two more muscles and the neck muscles. Be on Monday, you will be get more insights onto that programs there and TMJ and its dislocation. Thank you so much. And you can contact us. Please criticize this. I have taken 10 minutes extra. Sorry for that because I need time. The videos I need to replay it again. Please post in the group how you felt about this session. Have you gained or I did said nonsense here? And please put your comments and any questions. I'm open for question and answer session. Dr. Joe, are you there?
Yes, sir. Thank you, sir, for the wonderful session. Now we can quickly go into the questions. So So the question is from Dr. Fatima.
Yeah.
The question is, sir, can you please explain again about the case where the patient had pain because of chronic use of anteriorly displaced disc and how exactly it caused trigger points in the temporalis?
Yes. The thing here is the chronically displaced because the patient had that yawning first. She had the yawning first, and that during the yawning it got displaced, and she only managed to take it back. She had initial 2 to 3 minutes that discomfort, but somehow she pressed or something, it went back to normal, and she was normal. Now she started using it. She started using normally, biting normally, but at one point of time, what happened is opening of the mouth is limited, and she was not bothered because she can chew it, she was normal, but after a 1 month 2 months time, she started getting pain even without biting, or like de novo without any stimuli. She started getting pain, so that is a chronic condition that was happening for her because the pain is referring, pain was there, but even without any stimuli the pain started coming there. So how we corrected this, how we identified this, I told you, I showed you the picture of OPG we taken everything, but there is not confirmatory or no problem with that. But what we have done is we started to take a soft diet, first of all, heat and cold onto the muscles. We trigger, find out the temporalis was the reason. So we asked her to do the hot and cold and soft diet for a week, and steroid, not this one, we can see that non-steroid anti-inflammatory drugs was given. Meftal is the one that I give. Along with that, if severe pain comes, only that time she is taken so that we can reduce the inflammation of the muscles and the joint, and massaging, the proper massaging of the muscle. And she is perfectly all right now. She can open the mouth. Earlier it was 32 was the opening. Now she's almost come back to 38 to 40. 3 weeks only we were into the treatment, and she got tremendous results. So muscle therapy, diet control, pharmacotherapy was required to solve her problem. Now she's fine so far. She's fine there.
Thank you, sir. The second question is from Dr. Fayaz. And the question is, in trismus, due to lower third molar pericoronitis or periapical lesions, will the releasing exercise for lateral pterygoid help to relieve trismus?
No. Here you have a third molar. It's an infection. I did not cover that. Trismus due to third molar infection is a space infection there. You have to control the space infection. Once the space infection is controlled, the patient will automatically get relief from that because the muscles are not involved here. So this is not trigger zone form here. It is a space infection due to the bacteria. If you control that, if you remove the coronal, the third molar or the pericoronitis is been cured or cleared, patient will come back to normal. There is no problem there.
Right, sir. So then we have another question from Dr. Smriti Singh. The question is, what is the permanent treatment of trigger points?
There is no permanent treatment, doctor. There's not a chip like you put it and it will get cleared. Imagine a patient is very soft diet. One suddenly day she want to eat a chicken, and she ate chicken and suddenly bite onto a chicken piece, and oh, she got a problem there. So any time, any point of time you can get, but the treatment option is to find out what are the trigger points, which muscle is involved. Once you identify that, the best way to treat is to do the muscular massaging exercise, the exercises like mandibular movement exercises or the muscle exercises, which we are told you the massaging exercise. That's the first line of treatment that can be done to relieve the trigger point. This trigger point can again reoccur at a different situation. There are no permanent treatment for trigger points, but if you know how to teach the patient these exercises, if it reoccurs, patient themselves will start doing the massaging, and you can see the relief by the patient itself. If it doesn't happen, he will come. Then you might have to give additional support with something like a soft splint sometimes, or maybe analgesics or some kind of drugs you might have to prescribe to support that.
Thank you, sir. So next question we have from Dr. Devyani Ellen, and the question is, sir, if the nerve convergence occurs then why is the pain referred only in some conditions and not generally?
That's a very good question. That is usually it happens in a chronic condition. Try to understand. It happens in a chronic condition. Initial condition you will never get referred to. For heart attack, if you see, initially it won't happen. It happens in a chronic, constant time. It happens. The things is happening constantly. It is happening. That time usually it happens in a chronic condition. So that is one reason which I can tell you about why not all condition doesn't happen, but in a chronic kind of condition it happens. Second thing is multiple ramifications. The heart is involved by many muscles and surrounded by many muscles that attach that. Same way, our stomatognathia system is so sensitive. It has been supplied by multiple nerves. There are motor nerves, multiple motor nerves. I told you you have 26 neck muscles, 43 facial muscles are there, which has got motor sensory. Then we have tongue, which has got a special sensation. It's all represented in a different parts of the brain, not only in cortex. It goes to cortex, to go to thalamus, it goes so many areas, it goes represented. So when an area is represented by multiple, supplied by multiple nerves and represented in the brain by multiple areas, you have this referred pain because of the convergence occurs there. Otherwise, it's straightforward. It goes there and come back, goes there and come back. But in face, it's not like that. Sensory, special sensation, proprioceptive sensation, and motor, and mix, all are there in face. That is why the face representation have got more of a pain compared to the other area. GIT has got more effort pain after that because of the gastric I told you, because of the abdomen area is supplied by multiple branches of plexus of nerves are there. That is the reason.
Thank you, sir. Up next, we have a question from Dr. Prashant Jacob. The question is, what about muscle pain due to simple lactic acid accumulation due to overexertion? What's the treatment of choice in such cases?
In such cases, if it's like lactic acid accumulation is there, the simple thing is you have to either rest for some time, rest for some time. Do not be very aggressive the next time. Slowly do it so that the muscle can get that limit can be crossed, and so it can pump out that lactic acid. So slowly you do. So that is why once you do not run for a month or something, and suddenly you start running, you get muscles get cramped the next day. So the next day, it's not better to you vigorously do it. What you do is you do it slowly you do it, and after sometimes the muscles get used to that, and all those things will get used to that. The limit will be determined by the muscles, and slowly do. So that is why once the patient has got a trigger points or this has happened, you should always recommend the patient a soft diet, which many people miss that. 1 week soft diet, you tell the patient. And tell the patient, if you feel yawning, control it. Do not go for like, oh, yawning. You control it somehow for 1 week time. Why? Slowly let the muscle release that lactic and let the muscle come back to normal. And then you can go back to normal.
Thank you, sir. So we have one last question from Dr. Anchal. The question is, in some cases of ortho treatment, we have to raise the bite. Does that cause tension in the lateral pterygoid and trigger points in the same?
If you do it for around 1 to 2 weeks, that is why even any bite planes, you can't give more than 2 weeks time. Nobody gives in 2 weeks time, especially in adult orthodontist, you can't give it for more than 2 weeks time because it can cause a drastic problem there. So unwarranted use of this bite plane or temporary occlusal bite opening, you can't do it more than 2 weeks. So whatever you have to plan orthodontically, if you want to bring out that crossbite tooth outside, or you want to open the bite for some reason, then you have to do it, plan it such a way, maximum 2 weeks time, within 2 weeks time, nothing much can happen, and you do not open it beyond the rest position of the mandible. There's something called rest position of the mandible. If you open much beyond the rest position of the mandible, then only the stretching will happen. The mandible has got a limit of opening is there. If you go beyond that, definitely it can injure. That is why even appliances like Twin Block or BioBlock or any Even in your trainer treatment, if you see the thickness of that one is so such that it doesn't over open the mandible beyond the rest position of the mandible. So that is one important thing that you have to see when you're opening the bite in orthodontics or interceptive non-functional cases also when you open the bite.
Right, sir. So we have one last question that has popped up. Question is, does any muscle pain arise due to faulty IANB injection?
Yes, you can. You injure the muscles. You injure. Sometimes you can injure the which muscle is attached on to that. So it's your either medial pterygoid is the muscle which is commonly attached. So if you injure that muscle, you can definitely have pain by opening the mandible, or 2 to 3 days you can use that. If any nerve is involved, also you can have. If sometimes the ligament, the the mandibular ligament, if you injure, then also you can have pain. Definitely it can cause, but it's not trigger point pain. It's like direct injury onto the muscle fibers. You poked or you broke the muscle fibers or nerve ending somebody you broke. That is why, and it is self-healing. It will heal by within 2 to 3 weeks time. It will heal if it is not a very drastic one. It is self-limited and healing will be done. Do not worry about it. 2 to 3 weeks time, it will be all right.
Right, sir. Sir, I guess that covers almost all the questions. So thank you so much once again, sir, for the wonderful presentation. And thank you guys for staying in until 9:52. So see you all tomorrow. All those students who are here, please note there's a session tomorrow under the title Exam Alert discussing topics on conservative industry and endodontics. Please attend the session and make the best use of it for your exam preparation.
I just have a request for those people who are listening, even if it's a practitioner, even if how many years into practice, just listen to tomorrow's lecture. You will get lots of points which will be helpful for you. And if you are a senior practitioner, if you have your cousins, if you have any of your family who is doing PDS final year, first year, whichever, please do refer to them. It's a free session this week and next week. Also, it's a free session we have planned for entire final year subjects, and third year subject also is there, like oral pathology is also there. So please do support us. Please do refer to us. Your referral, your good heart is what make us to come and present it again and again at topic like this. So please do support. That's all what we require. Friends, thank you so much. Dr. Joe, can we wind up?